All right. Hello, everyone, and welcome to today's webinar. My name is Cynthia Klein, and I'm from the Take Heart team. I'd like to thank you for joining us today for what I'm sure will be a very robust discussion. I was actually thinking this is our fourth session that we've had so far, and today's discussion group is going to be around patient safety while resuming in-person cardiac rehabilitation program operations. I will be led today by Dr. Hisham Scally from Brigham and Women's Hospital, as well as Kate Trainer from Massachusetts General Hospital. You know, just as a brief recap of where we're at with Take Heart, partner hospital cohort 1 activities continue to be on hold. If you are in cohort 1, we have reached out recently to kind of get an assessment of where you're at with your program and try and understand better when best to resume. You know, at this point, we are likely not to resume for the next month or two, and we will check back again probably in late July, August. Give some hospitals some time to get their cardiac rehab programs restarted. You know, in the meantime, we are continuing to initiate Affinity groups such as these, and these are events that are open to anybody, but we do really encourage you to join the Take Heart learning community if you haven't already. By joining the learning community, you'll have the ability to get some additional updates on sessions like these. It's the opportunity to get access to new resources. You'll even be given access to the private side of the website where you can continue some of these discussions, some of these chats with your colleagues. And then we'll continue to update some of the materials that are on the website too in terms of resources. So from here, I'd like to pass it over to Steve Hines, who's going to be our moderator for today's event. Steve?
Yeah, thanks very much. And we just want to remind people at the start of the event that these affinity groups are really forums for peers to talk with and learn from each other. And Hisham, Kate, and the others that we'll be introducing here in a few minutes have great expertise, but I think that they also see themselves as collaborators and peers with you, all working to do the best you possibly can for your cardiac rehab patients. So we want on today's call to learn and share with each other and focus the conversation today on insights and advice around safely reopening Insight CR programs, since there are a lot of challenges and we're looking forward to discussing them today. So we want to just let you know that we want all of you to be involved using the chat and the polling features. So as far as the chat features are concerned, those should be pretty straightforward to use, and we've got some instructions on those just coming up. But let me start by introducing you to Kate and to Hisham. Hisham is the principal investigator for the Take Heart program and the associate director of cardiac rehab at Brigham and Women's, while Kate is the director of cardiovascular disease prevention at Massachusetts General. And then I'm delighted to have Connie Wilson from Davies Community Hospital in Washington, Indiana, Deb Stubbs from Memorial Health in Marysville, Ohio, and Jimmy Burnett from Conway Regional in Conway, Arkansas, on the call today. They're going to have great insights to share that we're looking forward to. As far as the chat function goes, to ask a question or to make a comment, you just click on that little conversation icon on your screen there at the bottom. If you don't see it, you may need to move your cursor across the screen to make those icons show up. But if you will set the field to all participants, that's key, so that all of the panelists plus all of the people in attendance will be able to see it. So don't click all attendees. If you click all participants, then we'll be able to see your comments or your questions and respond to them as the event proceeds. And if you'd like to try the chat function just to see how it works, by all means, just send a short greeting to the group, and you can see how that works and pass on a greeting to your peer. We have been displaying a polling question on the side of your screen there. If you haven't yet, click on your answer to this first question about what best describes the current status of your hospital CR program. And then once you hit an answer to a question like that, make sure that you click the submit button. So we're going to close out this first question now so that we can display the results in just a second here. So as we look at this first question, we've been asking this each event about the status of CR programs, and we should see the results come up here pretty shortly so that we can see the status of the respondents on today's event. So everything in the past, we've seen responses that have ranged this full gamut. And a big change today from in the past with reasonably normal operations being in place at a number of, almost a majority of the facilities. So that's good news, and that makes today's topic even more important. As we move to the next question, we're also interested in having you speculate on when your on-site operations will resume. Obviously, if you're already open, it should be pretty easy to answer that question. But if you're not yet, we're interested in seeing, do you think you're going to be resuming later this month or sometime later this summer, or is it going to be into the fall or later? So if you can provide a quick response to that question and then hit submit, and then Teresa, we can close out this poll and display the answers, and we'll see where people stand on this question as well. On our last event, many respondents said that they were opening in later May, and that's consistent with how people answered this first question. We'll see what it's looking like now. I'm guessing it's going to be mostly A's or B's, but we should see here in just a second. All right, excellent. So lots of people are resuming activities, and not too many are delaying things until August or the fall. So we're delighted that you're resuming or morphing back towards more normal operations. If we can go to the final question now, we're also interested, just as we gear up for today's event, to get your assessment of these safety issue categories that are mentioned here. If you had to pick the top two of these issues that as you've resumed operations, you struggle with the most, which two would you pick? And there's, I'm sure, challenges in each of these areas, from determining, who you should be inviting back, to how you screen people, to safety issues during your on-site sessions, to ensuring the environment is cleaned and safe, or what you do if somebody tests positive for coronavirus after they've been at one of your sessions. So if you can pick two of those real quickly, and then hit the submit button, and we will close out this poll and see the results for this in just a second here. I guess if we were thinking, we would have set up an internal poll to guess, or a pool to guess responses would be the most common, and we'll find out here in just a second as soon as Teresa can display the answers. Safety issues during the on-site cardiac rehab sessions seems to be the strong winner as far as some of the issues both at the start and the end of the process, deciding which CR patients should be asked to return, as well as what you do if someone that has been there tests positive for coronavirus, and you need to respond to that. All right, so we will make sure that those issues get a fair amount of attention in our conversation today, and thanks very much for sharing your answers. We've organized things around those categories that we've been referencing. We're going to talk about some general safety issues, introduce you to a couple of key resources, and then really we're tracing the patient from the time that they get invited to return to your cardiac rehab center to what you do in the process as patients are arriving, the safety issues in that phase. Then during sessions, what safety issues are surfacing there. And then the last category is all of the safety issues associated with after the patient walks out the door. Obviously, you need to get your environment safe again before next sessions occur, and you need to be prepared for situations where a cardiac rehab patient is diagnosed with coronavirus. So those are the general categories. We're going to talk in each of them about what the key safety issues actually are, because we want to make sure that you're not overlooking something, and we also want to reassure you that you are thinking about the key issues, and then we want to get some practical insights from people working in programs like yours about how to deal with issues. And then we want to make sure that we have plenty of time for sharing from peers and from the audience using the chat function. So at this point, I'm going to turn it over to Hisham to guide the discussion from here.
Thank you, Steve, and welcome everyone to our fourth webinar in this program of Take Heart in the setting of COVID-19. I'm sure, as you know, this has been a terrific program so far. We had a lot of good feedbacks, and I've been really delighted to share a lot of advice and listening to what people have been doing over the last couple of months with this unprecedented times. I'm really excited to have Kate Trainer from across town with us today. She's very experienced. She's the past president of the AACVPR and has been already on the forefront of many initiatives, part of AACVPR, and this is unprecedented times in terms of how do we deal with COVID and a pandemic with cardiac rehab. And as everyone else, we're all trying to be creative, but also trying to provide a very important service to our patients while also trying to be protective and safe for our patients and staff. So welcome, Kate. And we also have three very experienced panelists who will be sharing their experiences. Connie Wilson from Washington, Indiana, Deb Stubbs from Memorial Health in Marysville, Ohio, and Jimmy Burnett from Conway Regional in Conway, Arkansas. So I look forward to a very rich discussion between the five of us and also between the other 100 people who are participating and vision in this webinar. So please do use the chat box as you'd like to intervene with questions, advice, or comments. And our staff from ABT actually will convey that to us. And we can also unmute you at some point if you'd like to make a voice comment. Good. So without further ado, so this is what we're going to be talking about, as Steve mentioned. And we're going to follow the pathway that patients get through to get into their rehab session. So how do we select the patients? What do we do when they come in? What do we do during their rehab sessions? And what do we do after they leave the session? And before we start going into the details, I'd like to remind everyone that this is a very fluid situation with guidelines, recommendations, and policies and standards of care evolving over time, at pretty much every level, at the national level and internationally, but also at the national level, the state level. And I'd urge you to follow all those recommendations from up top all the way to your facility standards and recommendations. This is, as I mentioned, this is an unprecedented event. And so we are coping and learning how to deal with a lot of unknowns. And we're trying to use a lot of common sense. There is some data out there. We're trying to use the data whenever we can. And other than that, we always put safety first, and then how can we help our patients? AACVPR came up a couple of weeks ago with a considerations document about how to resume in-center services, both for cardiac and pulmonary rehab. And the link is on the website, on the slide here, and we will share that in the chat box for everyone. It is also available on the Take Heart website. So I'm going to pass it on to Kate to tell us about what the guidance document has been talking about. Kate?
Thanks, Hisham. Welcome, everybody, and shout out to all of you 118 participants and attendees today. I'm really encouraged by your support and interest in this topic. And I'm also very encouraged by the fact that so many of you have resumed operations or are gearing up. So that really makes me feel good, and I'm excited about seeing us come back and be able to serve patients in facilities. So the AACVPR got to work very quickly when the pandemic was really starting to, the impact of it was being felt across the country. The first step was the organization developed a task force, and on the AACVPR website, a page dedicated to COVID-19 resources. So I would encourage all of you to take advantage of that webpage if you haven't done so already. The second step, of course, was to answer the call and the concerns that we were hearing from so many of our members across the country about, what to do, how to approach patients, how to get back on track afterwards, and really what were the key considerations. Hence, we developed the Reopening Your Program Safely guideline, which is linked here on the slide. And again, would encourage you, if you haven't already gone to it, to please do so. So it's really set up in two ways. Well, the first is alludes to some of the external factors that Hisham has mentioned, those external factors being governmental and local municipality considerations, and then internal factors, and those are the things that are going to pertain to you in your institution. And there's three words really that I want you to remember that will, there's information about these three considerations in the document, and it's very straightforward. Screen, clean, protect. So the screen has, there's guidance in here for screening patients and staff. Protect is about the protection for you, for your patients, and then finally cleaning and recommendations around approaches to keeping things safe and to minimize transmission of droplets. So that's a very quick overview of what you will find in the document, but again, just remember those three key principles, and you should be able to find answers to those three kinds of considerations and principles in the document. The other effort that the AECVPR has had that I think is important for you to know is separate from education and trying to provide these resources. There's been a strong effort around advocacy and reach out to CMS, both about telehealth on a number of different considerations related to telehealth reimbursement, of course, being one of them, and secondarily to have us to some consideration inclusion of COVID-positive patients in pulmonary rehab programs after, when the time is right for them to assist with their recovery, because as we know, that can be long and challenging. So more to come on that. I hope that we're going to get the response that will back from CMS. We don't have that yet, but important for you to know that all of that background work has been happening. So stay tuned.
Thank you, Kate. Very enlightening about the document. And I like the three words message. You said screen, clean, and protect. So we'll remember that. That should be like a motto for in our rehab program. And with that, I mean, as we said, it is very important to listen. And I'd like to ask Connie Wilson from Davis Community Hospital in Washington, Indiana. How is she doing with her program? How she has opened that? And what has she found important in terms of listening to the patients, and how does she accommodate their concerns and longing? Connie?
We opened our program on May the 1st, and we started with just a few phase 3 patients because they were kind of the experienced patients to kind of see how things were going to go as far as keeping things clean. We're really fortunate. We're in southern Indiana. We're in a very rural community. We didn't have a huge COVID population. The majority of our patients that were COVID positive were kind of associated with a nursing home, so it wasn't really out there in the community rampantly. So I think that's kind of protected us to where we could open up a little bit quicker because of that. But we started with our phase 3 patients, and then we had them for about a week. And then May the 11th, we opened back up to phase 2. And the big thing with that was, we were trying to get some of those patients back that we had to halt whenever they stopped the program. And some people were comfortable with coming back and others weren't. So it was really important, I think, that, we didn't judge anybody. If they weren't comfortable coming back, we just reassured them on the changes that we had made. The hospital was still screening patients coming in. They were limiting visitors still. When patients everybody wore masks in the hospital, so we're wearing masks, patients are wearing masks. We're having them, of course, wash their hands when they first come in or use the foaming sanitizers. They have gloves available if they want to use those. And then, of course, we're, as Kate said, cleaning. There are cleaning wipes for everybody if they want to clean their own stuff, but we also, the staff is very involved in making sure everything gets cleaned. We used to do 6 patients. We backed it down to 4 so we could do social distancing. So we make sure that when they're on the equipment, there's at least 6 foot in between them so that they're not real close to each other. So we had to rearrange things just a little bit. But, when I call new patients, and I've had several new patients start since we've opened back up, and I just try to let them know, the measures that we are taking to protect them when they come into the facility. Because I think there's still a lot of fear about going into hospitals because of the COVID.
Good. No, that's very and very important step to reassure patients. I mean, with all the cleaning that's happening around the hospitals, it probably is safer to be in the hospital than in the grocery stores, for example, or anywhere else. So I think that's very, very important message to keep out there. And you're right. I mean, there is a wide variability in different communities about how rampant COVID and how many people were actually affected by this. And so certainly it would be different if you were closer to New York, New Jersey, as opposed to you're somewhere else, and then your ability to actually resume some kind of normal activity. And so that's why it's very important to go on with that reassurance step. And so, as you said, that's why it's very important to actually figure out who are the patients we can call back and have them resume their on-site cardiac rehab. And so you always have to balance your risks and benefits. And in terms of benefits, nobody's going to deny the benefits of performing or enrolling and attending cardiac rehab classes, but then the risks are actually are on both fronts of not attending the cardiac rehab. So there is something to lose there for certain patients, but also there is the risk of spreading the infection for patients who may have the coronavirus or maybe COVID positive and not know it, or patient recuperating from that, or for the staff. So that's why there is, and as we know, patients attending cardiac rehab might be a population at risk from severe complications from COVID, given that they all have cardiovascular comorbidities, other diabetes, and are also in the higher age group that we are concerned about. So there is always the balance of risk and benefit that we have to observe and figure out which patients we should call. And the guidelines from AACVPR actually do mention that we should probably target the patients who are most likely to benefit from cardiac rehab. And I think that's something we'd have to adjust on a patient-by-patient basis, and not, there isn't a blanket statement that all patients over this age with this condition are the most likely to benefit. So I think we have to address that on a patient-by-patient basis. And as you said, we are reducing the capacity of our programs to observe that physical distancing between patients and staff. And then you have to actually be cognizant of patients who are worried to be there, and you might still, even with all your reassuring words, you might not be able to convince them to come to the program. And you have to observe, to figure out what is the environment that they live in terms of whether they have safe transportation, are they taking public transportation to come to your rehab program versus taking their own car and they're on there by themselves the whole time, or not. So there are a lot of things to consider there, and I'm sure you are all very careful about that. So these are all some points that we have put together for you to think about. Kate, do you want to go about what the document said about patients to select and how to bring them in?
I think that is really, and as you could tell from the polling question, it's the biggest questions and one of the biggest challenges that we face. I mean, if you look at the CDC recommendations, in their definition of the patients that you are considered high risk, those are also the patients for us that are high risk from the standpoint of exercise. So, to keep those patients away from the center for safety reasons is abundantly clear. However, guiding them in exercise without the ability to really work face-to-face with them is challenging for us. So my recommendation would be to review those CDC recommendations, some of your internal institutional recommendations around patient selection, and talk with both your medical director and the patient's physicians, whether that's the pulmonologist or the cardiologist, and work together to individually make decisions about some of those people that are a little bit higher risk, because certainly they may not all be held out, but I think it does require a little bit of careful consideration and sort of team collaboration around that. There are many patients that we might feel are ready to come back, and as we heard, there's a lot of reluctance on patients' part. In fact, we've seen about 30% of patients concerned about returning to the center. So I think marketing a little bit and being very clear with patients in terms of what you're doing around screening, cleaning, and protecting is going to be very worthwhile, just to help them understand that. And even with that, it may not necessarily change their minds or sort of satisfy their concerns. We did talk with our patient family advisory committee, and that was really one of the foremost questions that they had for us was how do we know that coming in is going to be safe and that we're going to be protected? So it definitely is something that we're all grappling with. The one other thing that I want to say in terms of resumption of activities is you really want to think a little bit about in terms of, there's on the slide here, there's, what are the issues that surface in the considerations. And, our staff love them, but they're very married to these hard copy charts for patients and want to be able to have all of their information at their disposal whenever somebody's face-to-face with them. And in reality, we're not going to be able to do that. Not going to be able to have the charts anymore, or even some of the same handouts we were accustomed to using during our educational sessions. So there are definite program implications here, which are in the AACVPR document, to be thinking about kind of what you've done to the pandemic point and how some of that may need to change afterwards for consideration around protection and safety.
Thank you. Very, very insightful, Kate. And also, again, pointing out the fact that we have to be flexible and change some of the things we used to do for many, many years. Deb Stubbs, the director of the Wellness Center for Memorial Health in Marysville, Ohio, has very kindly accepted also to join us. And I'd like to ask you, Deb, to describe what is the process that you have adopted in reopening your program.
Actually brought cardiac, we decided to bring cardiac and pulmonary rehab back safely because we had such a large adult fitness, which is made up of our phase 2 and community members, that we were concerned about commingling them. We actually took our education room, put 8 pieces of equipment, moved our telemetry in there, and we are separating our cardiac and pulmonary rehab patients into a separate space. And so we can still have our adult fitness and employees exercising and our rehab patients exercising, but separately. That's a little less productive, but our patients have appreciated that additional safety feature, that they feel like they're not in with 30 or 40 other folks, which they were concerned about. That was one of the concerns we heard when we were calling them and coming back and restarting. We are also a little bit less flexible with when people can come. Before with a little more of a open kind of come when you want. Now we're really structuring because we've got the ability to do 12, but we're doing around 4 at a time. And so we're sticking to very much our appointments and trying to make sure that people are coming on time, leaving on time, so we can, make sure we're cleaning in between. And then also if somebody's not going to be compliant with attendance, we are discharging those folks a lot sooner than we would have otherwise.
Thank you. And so you've opened the program to pretty much anybody who's actually willing to come. You haven't made a tiered or a priority list of who are the patients that come in it.
No, we opened cardiac rehab on the 11th of May. We opened pulmonary rehab on the 28th of May. And then we opened our adult fitness and employee fitness on the 1st of June. So we very much brought it back in staging. And so that way everybody could get comfortable and we could figure out our processes and learn as we kind of work through everything.
Excellent. Yeah, that's very enlightening actually. And so this brings us to the point that it is very important to have a plan and a reopening plan in place for your program. These are just 2 examples from 2 different sites of what they have. And it doesn't have to be fancy. It doesn't have to have a lot of charting or diagrams or anything like that, but you do have to have a plan for the different aspects of this. Who are the patients you're bringing in? What are your staff accommodations and so on? And how are you going to be screening and filtering patients when they come in? And what are you going to do in terms of facilities of signature or for distancing, for example, and so on. So I thank the people from the Wellness Center at Memorial Hospital and from the Loudoun County in Inova for sharing these with us. And both plans actually are shared on the Take Heart website. So I would advise you to look at those if you're looking for examples, but certainly you can accommodate that to your local setting, still based on all the recommendations from the CDC, national, and from your infection control departments. So once you have selected which patients are coming in and decided when you're gonna open your program, I think the next step is really what are you gonna do when the patient arrives, and you'd have to figure out, what kind of screening are you going to be performing in terms of questionnaire or temperature taken, and how are you going to allow them to get into your gym. And so also, as Kate mentioned, limiting any exchange of any physical material. So whether it's the paper chart or any consent form to be signed or anything like that, how are you going to be able to do that? And Jimmy Burnett from Conway, Arkansas, actually has very kindly also agreed to share their experience with us. And so, Jimmy, could you tell us how you've changed your operations?
We never actually closed our facility. We just limited the people that were coming in. We do screen them. Where have you been? Have you traveled? Any symptoms? Everyone that enters our door gets their temperature checked and needs to be masked. We ask patients to actually bring their own mask just for conservative of the PPE that we have. Employees are also, and we're lucky, right before this happened, we moved to an off-site facility. There's no one else in our building. We have the space to physically distance everyone. We limited our classes. We have 3 people at a time, and we're able to clean everything in between. So all of our screening, and when I start a new patient, we go through all of this with what they're doing. I do the questions over the phone before they actually start. And then, like I said, every time someone enters our door, their temperature is checked, and then they're asked to go straight to the restroom, wash their hands with soap and water. We're having them use hand sanitizer in between each piece of equipment. Those are just the things that we're doing.
Thank you. Now, again, even though you haven't closed the program, it just shows that how flexible you were in adapting to all of this. And so, it's very encouraging for the field. Thank you for sharing that. Kate, how have you changed your operations?
So for me,
we also are off-site, but we're in a private building, so that has added a little bit of a layer because we have to also now work with the building operation team and management around, being certain that what we're doing is asking patients when they arrive at the building to call us so that we can then let them know when it's safe for them to come upstairs, because our plan is to bring them right to the gym rather, bypassing the check-in point, front desk. We're bringing patients in one at a time and having them come directly from the front door of our facility right down to the gym, and then going to an appointed place where the staff will direct them so they can maintain that physical distancing. So there's a whole orchestration of patient flow that's entirely different than anything we've had to do. And I think the challenge here is, one of the things that cardiac and pulmonary rehab professionals that we've always prided ourselves in is trying to remove barriers for patients coming to programs so that we could get more and more patients coming to programs and participating. And yet this is really going to challenge that. So any way that you can think creatively around working with what are some of those challenges, I hate to call them barriers, but, working with some of those challenges to keep patients coming and being responsive to them, I think in the end will be very worthwhile, because we certainly don't want to lose those patients that are interested in coming in and seeing us in center.
Thank you. Yeah, so I think that's key, really, to, as you said, take out the barriers, but at the same time, allow patients to come in as a safe manner as possible. We had an audience question here, but I think in the interest of time, we might skip it. Actually, no, let's leave it, but I'll open it for 30 seconds and we'll see what people are thinking. So could you please mark, out of the 5 choices available, which safety issues related to conducting on-site cardiac rehab sessions have you been most challenged by? Apparently, sorry, so this question we'll pass that. If we have time at the end, we might ask it again and ask for your opinion there. So after we talked about how you get patients in, let's talk about what are you doing to maximize safety during the cardiac rehab session. We've already addressed some of these things in the prior segments, actually. But again, it's really what are you doing in terms of distancing, distancing patients, masking them, changing the hours, as we said. And so I think masking is a very important topic. I've seen a few comments in the chat box. I'd like to ask Connie, what are they doing in their program? The CDC and other and the national recommendations are varying, and local recommendations are varying, other than actually masking. But we don't go into details about what specific masks are recommended. So I'd like to ask Connie again to actually tell us what she's doing in her program.
We are, the staff is wearing the regular surgical mask, and then we have cloth masks for our patients, just cotton ones mostly. Some of them have their own surgical masks that they're wearing, but I don't recommend the N95s for the patients because they're too difficult for them to breathe through.
Good. No, I think that's very valid. The N95 for the patients, unless you've actually fit every single patient, would not be feasible. And this is beyond the fact whether they're available for everyone or no. So I think that's I completely agree with that. N95 masks are not recommended for patients at this stage. And so you are doing a universal masking, though change. So the staff is wearing a surgical mask, and the patients are wearing cloth mask, and that could be reasonable in an area where the prevalence of COVID is extremely low, the transmissibility is actually extremely low, so it's still a very safe procedure to have. Kate, what are you doing at Mass General?
So, as you know, Hisham, being from the same Boston area, it's masks. Everybody's got masks on, and they are surgical masks, are actually giving patients fresh masks when they arrive, because maintaining the integrity of a well-functioning mask is so very important. In terms of N95, there's been some controversy around whether staff should be wearing N95. So while exercise isn't necessarily aerosolizing, certainly there is more droplet production and potential for transmission. So definitely need to be thinking about the staff protection from the standpoint of eye protection as well as masking, because, any droplet coming at you can certainly enter through mucous membranes and all in eyes. So either goggles may not be a bad consideration for your team, or the mask with a face shield. So both of those will probably be prudent. So remember, it's all about protect. Patients, may struggle a little with those masks. And again, I understand that this is regional, and we're talking, myself and Hisham are talking from an area that experienced, a very high volume of COVID positive, and, it was really a very challenging time here through the months of March and April, and even into early part of May. So, we are coming from a very different perspective, and it's been very restricted here between state guidelines, institutional challenges and management. And so I think you have to first and foremost step back and think about where are you and what is most important for your region and the prevalence of COVID in your region. Maintain the focus on those three tenets, and talk with your internal resources about really in your setting what makes the most sense. But certainly masks are just not an option here, and patients are going to struggle. And you may, I think you've probably heard this 100 times already. You may need to adjust down the intensity of the exercise, but I think that protecting yourself and patients is paramount, and that there may need to be some adjustments on the basis of that.
Absolutely, I couldn't agree more, Kate. It really depends on the prevalence of the disease and the risk of transmission in your area and in your around your facility and your patients. And so definitely in the Boston area, we've been hard hit. And so the prevalence of also asymptomatic COVID patients is quite high. So we're assuming that everyone needs to be actually wearing a mask and face covering. And as you said, there isn't a lot of data to say that exercise is actually aerosol generating, but there isn't a lot of data to say that it is not. So we elected also to go on a more safe and precautionist approach to say that we should actually protect our staff, because if they are encountering a lot more patients, then patients are encountering each other actually. And so the exposure is much higher. So we have recommended that the staff wears an N95 whenever possible. The patients are asked to remain masked, but as long as they can maintain that. And as you said, we are also decreasing the expectations in terms of exercise tolerance and exercise capacity. And I think that's some of the adjustments we have to make in our program. So I think that's very important to observe that and really be, again, flexible and adaptive to your area and to what your local recommendations are. But I think it's screen, clean, and protect. I really like that. Here, it's the aspect of protecting both the patients and the staff. And so you want to maximize that safety and not allow patients actually to contaminate each other. So we don't want to turn this into a combat zone. When the patients are coming in, we're still working in that prospect that we are trying to reassure them that this is safe to do and it's good for them to attend their cardiac rehab classes. But we don't want to also give the impression that they're coming into a combat zone where everybody's fully gowned up, wearing face shields, masks, gloves, and gowns, and so on. But that we are doing this for their own protection. We're using face masks, eventually shields as well, and spacing patients with each other. How about taking their blood pressure, EKG leads, and all that? How are you guys doing? So, Jimmy, for example, what are you guys doing in terms of monitoring?
As far as monitoring goes, we actually place the leads on the patient ourselves, getting it there so they're nowhere touching. We have a dirty place to put them before they are cleaned. And blood pressures, we have one blood pressure cuff per patient, and they are absolutely clean before they are used on another patient.
Good. No, that's very reasonable. How about blood pressure?
With the blood pressures, the cuffs that we use on the same patient throughout the session, and then it is put in the dirty area before it's used on another to be cleaned.
Okay. Good. Yeah, so again, trying to isolate that. Yes, Kate.
I just wanted to add a little bit about the EKG and blood pressure question and discussion, and that's covered in the AACVPR document. And this is one area where I really would urge people to look at the document as well as other resources on the website to really think through best practices and necessary minimum practices when it comes to ECG monitoring and blood pressure checking. I mean, certainly I'm not suggesting that you don't do that, but I think that, you know, to apply and to maintain practices that we've done forever without really thinking about what's the best use of the technology or the strategy for a particular individual patient is really all I'm asking, is that you step back and think about really what does this patient need, and are these things completely necessary, and how often are they necessary? Because this is really the time for you now to think, work smart, not harder, and to limit your exposure and coming closer to that patient than 6 feet. You know, you do have to protect yourself, and you do want to be certain that we're doing all we can to protect patients. So I would suggest rethinking the frequency of the ECG monitoring and the blood pressure checking, unless there obviously are clinical considerations that supersede and override that. But again, it's all about thinking, you know, out of the box a little bit. And I just have one thing I want to go back to. I think it might have been on a prior slide, and I know it came up in a prior Take Heart webinar. It was around, somebody very creatively suggested moving exercise outside. And, you know, I think certainly there's some interesting wisdom in all of that, but I will want to just remind you and caution you against the fact that if that is your cardiac rehab and you are billing for those kinds of visits and interactions, that you have the same need to meet the standards from the standpoint of having emergency preparedness and a physician available. And the reason that I say that is sort of born out of experience. We had many years ago a maintenance program actually at the local university at their track, and we actually had a cardiac arrest at the outside track. And fortunately, we had all of the emergency equipment and the ability to summon help very readily. But those are, as much as we're thinking about COVID considerations, we can't lose sight of the fact that we still have standards to maintain and practices to uphold. So in your creativity, just be certain that you're also double back and checking to be sure that you're some of those necessary guidelines and regulatory considerations.
Excellent. Yeah, that's an excellent point, Kate, about moving cardiac rehab outside. And so you certainly want to be ready. You want to check that with your risk management department and make sure that you are still able to perform and provide the same level of safety and exercise that you'd be doing in an indoor program. Connie, was there anything else you wanted to add in terms of how you changed your program in your performance in terms of safety?
I just want to tell people that it's just really important that when we make that initial contact with that patient, that we take that time to really assess whether they are going to feel comfortable coming in to see us, and if not, offer them support for home.
Good. I think that's a very good point. Yes, not everyone we will get a referral for will be coming. Not everyone who we assume will be coming will actually come. And so we should be able to actually understand that and offer them an alternative. And so I think over the last 2 or 3 months, a lot of programs have been able to offer some kind of remote and home-based rehab. So this is maybe the time that we may be able to continue to do that. And hopefully with the efforts by AACPPR and others, we may reach a point with CMS where we get reimbursed and be able to bill for these. But I think it is here to stay. It's just a matter of really being able to get to that level where we are getting paid for it. In the interest of time, I'm going to move to the next stage of our cardiac rehab operation. So what do we do after the session ends? And so really, again, it goes to that second word that Kate used about cleaning. So after we screen and protect, it's also cleaning again. So cleaning the equipment and facility, and we've had a lot of adjustment there between spacing appointments and so on. So Kate, I won't spend a lot of time on this. I'd like to ask you directly, what do you think about that, and what is the AACPPR document mention about this?
So the hospital grade disinfectants are really what's recommended, and I think that every institution, should have that and have received guidance around that, and certainly allowing for the proper dry time is just minimally necessary. The other kinds of considerations that you might have are depending on what types of flooring you have in your gymnasium. Some have rubberized type surfaces that can be easily cleaned, and others have kind of an indoor-outdoor carpeting. And if that's the case, you may want to think about putting down some kind of plastic covering over the carpeting so that it's easy to be cleaned in between patients. Some facilities have begun to use physical barriers, transparent physical barriers between the staff and patients exercising or around the pieces of exercise equipment. So all of those kinds of things would need to be disinfected and cleaned between patients. So in the chat box, there's some really wonderful kind of exchanges happening, and it seems as though all of you are getting it, that it's necessary to get people in there for the minimum amount of time, and then move them out quickly and allow for some adequate cleaning and dry time in between. So I think that it's clear that you are all already thinking about some of these things and just offering some other thoughts about, other types of considerations that may have been overlooked inadvertently. The other is air exchange. So, I think this has come up, and it's also in the AACPPR reopening document, that there isn't any hard or fast recommendations around air exchange in areas where there's exercise happening. I mean, certainly there are some expectations for patient care areas that are probably posted and available in your facility. But anything that you can do to increase the exchange rate of the air in the room would be worthwhile. And again, there's no standard that's been set. There's no goal that you need to, necessarily work toward. It's just recognizing that the more that you can recycle the air, perhaps the more advantageous that would be.
Yes, no, absolutely. Cleaning, and then the air exchange is another excellent point. I work in an exercise stress lab as well, and that's another point, another area where we have actually been working hard with our engineering department to increase the air exchange cycles in the exercise rooms, depending on what is your gym floor capacity and surface and ventilation. That's something certainly you might want to consider and talk with your engineering department and infection control whether it's something doable. Deb Stubbs from Memorial Health in Marysville. Any words of wisdom from your program that you want to share with us, please?
Probably for Ohio, one of the things that probably muddied some of programs restarting was we had gym rules, and I think making sure that you're able to communicate to your senior leadership that cardiac rehab is not a gym, it's a patient treatment, and making sure that we did have adult fitness and we did have employees, and we shut those programs down. But we kept physical therapy as an organization going the whole time and trying to make sure they understand that this is a treatment that's ordered by their physician and the patients want to continue. And what information can you give them in order for them to let you reopen? I had to go through the screening and cleaning and social distancing and protocols and masking and all of those things with my CMO. And once he was comfortable with that, he gave us the green light to open.
Very good.
I think that's really sage advice. I am really happy to hear that. And like you know, I tried to stay on the radar throughout all of the time that we were spent, because certainly, you know, getting back online for me was a non-negotiable, but certainly needed to be part of the administration's plan as well. So I think the more that you can advocate for your program and represent it the way that you've so eloquently done, really to be commended, and that all of us can learn from that.
Thank you.
Thanks. I'll ask Jimmy Burnett from Conway, Arkansas. I know you said you haven't closed the program, but what do you think your most important piece of advice that you want to share with all of us here today?
I would just have to say be diligent with the screen, clean, and protect. That's just the best way that it can be done.
Thank you. I couldn't agree more. Certainly, that's what we've been doing in Boston, and I think that's what has to be done pretty much everywhere. You just have to adapt it to your local environment and listen to your patients and listen to the local recommendation. But just really, as Kate and Deb have said, you have to advocate for your program so you're able to maintain the service to all of your patients and community. And Kate, any last words of wisdom?
Yeah, so I never only have one thing to say, right? If you haven't figured that out already. But I do want you to know that, you know, we don't have all the answers. And I think that, you know, we're all sort of learning together, and, you know, we're presenting best practices, you know, thoughtful considerations, general areas to review and consider as you get up to your programs up and running again, or keep them in operation. So I think if you continue to just stay on top of current updates, the AAC document is a living document. It will be updated as we learn new information and feel it's important to get the word out. So just continue to stay integrated, networked, and share. I mean, I think I've learned more in the chat today, perhaps, than, you know, I mean, I think that you are very creative. You're very smart. You have your patient's best interest at heart, your staff's best interest at heart. And I think that your commitment to that is going to keep you and hold you in good stead, and that you're probably doing as much as you possibly can. And I want to just urge you to keep that up and keep yourself integrated and, you know, current in terms of what we know and what we'll learn in the future.
Thank you. Thank you, Kate. I think this was a very enriching session. I'm really encouraged and inspired by all your ideas and creativity and what you've shared with us here. We had over 132 people attending this webinar. I think this may have been a record for this. And so I really want to encourage all of you, as Kate mentioned, to be open, listen to each other, listen to our patients, and stay up to date with the information that's out there. It's a very fluid situation for all of us, and I think we're going to come out stronger at the end of this. And our last slide, I believe, is the resources that we mentioned today in today's event. All of this will be available on the Take Heart website. And we have, I believe, a last poll question so that we can plan for what is the topic that would be most interesting to you in the next Affinity group. So if you don't mind answering this.
Yeah, thanks. And if you can answer that question, Teresa, I don't think we need to see the answers for this, but if you can just give us some input on where we may be going next, to then hit submit when you're finished. then we'll be able to close out that question. Just a couple of final reminders. There have been questions about accessing the materials, including the startup documents. We are going to start emailing the slides and any attached documents to everyone that registered for the events, just so that they can get those quickly, and then we'll follow up with the event summaries later. Our next call is going to be on Thursday, 4 weeks from today at noon Eastern Time. And we're going to focus that one on operational adjustment as you resume on-site cardiac rehab. We want to encourage you to participate in that. We'll send out a registration link and make those things available to you as quickly as we can. So thank you again. Thanks to all of our panelists today for great insights. We really appreciate that, as well as those that shared in the chat, and we will capture those comments in the event summary as well. So thank you very much for your time and for your participation today, and have an excellent rest of your day, and thanks again.
Thank you.
Thank you, everyone.